This is Dr. Hisham Ali Ibrahim. I'm a professor of ophthalmology in Alexandria University. Today's lecture is about orbital diseases. The orbit is not like any structure that you study in ophthalmology. The orbit is a cavity. This cavity acts as a socket for the eyeball. To understand the anatomy of the orbit, we must study bony orbital walls, orbital relations, orbital foramina, structures within the orbit. The orbit has a pear-shaped cavity. Its shape is a quadrilateral pyramid. It has four walls and a narrow apex. These four walls are the lateral wall, the medial wall, the roof, and the floor. The medial orbital walls are parallel to each other. They are so thin. Much of this thin wall is formed by the lamina papyracea, which means paper-like. It can be easily fractured. The orbit is related medially to the ethmoidal air cells and the sphenoidal air cells. The lateral walls are much thicker and meet the medial wall at the orbital apex near the optic canal. The lateral wall separates the orbit from the temporalis fossa and the middle cranial fossa. Radiological investigation gives accurate delineation of orbital walls, relations, and any abnormalities. We can revise the previous diagram together. The arrow is on the optic nerve, the medial and the lateral rectus muscle, the temporalis fossa, the middle cranial fossa, the ethmoidal air cells, and the sphenoid sinus. The diagram and its corresponding CT scan shows a coronal section at two different levels in the orbit, the middle of the orbital cavity and near the orbital apex. The orbital roof separates it from the anterior cranial fossa, while the thin orbital floor separates it from the maxillary sinus. The narrow orbital apex contains compacted motor and sensory nerves, and also vessels entering the orbit through the superior orbital fissure. The optic canal gives passage to the optic nerve, the sympathetic nerve, and the ophthalmic artery. The tendinous ring of Zinn gives origin to the four recti muscles. In the orbital floor, there is inferior orbital fissure, where the infraorbital nerve and vessels lie. The fissure becomes a groove, then a canal. Fractures of the orbital floor will result in numbness over the cheek. The overall orbital volume is 30 cubic centimeters. The volume of the globe is just 7 cubic centimeters. The eyeball rests inside the bony orbit on a cushion of orbital fat. The eyelids moves by the levator palpebris superioris and the orbicularis muscle, while the eye globe moves by the attached extraocular muscles. The visual impulse is transmitted through the optic nerve. The orbit contains motor, sensory, and sympathetic nerves. The lacrimal gland lies in the upper temporal part of the orbit. The lacrimal sac lies in the lacrimal fossa in the medial part of the orbit. Proptosis or exophthalmos is forward protrusion of the globe within the orbit. Proptosis is the most common clinical presentation in orbital disorder. The tip of the cornea lies normally 12 mm to 22 mm anterior to the lateral orbital margin. This is called exophthalmometric readings. This is a wide normal range. So, in early cases of proptosis, we can diagnose it by recording a change of exophthalmometric reading of the same eye or between the two eyes of 2 millimeters or more. This can be measured by a ruler or more accurately with a special instrument called Hertel's exophthalmometer. The latter uses a strip of mirror fixed to the lateral orbital margin to measure the protrusion of the tip of the corneal surface reflection on a scale. Enophthalmos is backward retraction of the globe within the orbit. There are some other manifestations for orbital disorders, like the presence of periorbital swellings, vascular engorgement, limitation of eye movements, and change in the fundus and optic atrophy. Most of our lecture today will discuss the causes of proptosis. The eye can be pushed forward in the orbit by many mechanisms. If a mass appears inside the orbit, if the normal orbital structure becomes enlarged, or if there is shallowing of orbital cavity due to a premature fusion of the skull bones during growth. These three mechanisms can be caused by congenital anomalies, trauma, inflammation, or neoplasia. Trauma can induce proptosis by many mechanisms. Damage of blood vessels can lead to the accumulation of blood inside the orbit. This can occur with direct eye trauma. Retrobulbar anesthesia that is used in many of ophthalmic procedures can lead to iatrogenic retrobulbar hematoma. Excessive bleeding may lead to serious consequences if the intraorbital pressure increased to an extent that may endanger the blood supply of the optic nerve. In such circumstances, it should be evacuated by a lateral incision called lateral canthotomy. Another mechanism of proptosis following trauma is surgical emphysema. The medial and inferior orbital walls are so thin, which separates the orbit from the ethmoidal and maxillary sinuses. When fractured, if the patient didn't abstain from blowing his nose, he can push air into the orbit, giving a peculiar sensation of crepitation on palpation. Carotid cavernous fistula can occur due to severe head trauma. The internal carotid passes inside the cavernous sinus. This patient had head injury in a road traffic accident. The turbulent blood flow within the fistula produces audible bruit. He complains of pulsating proptosis, congested enlarged conjunctival vessels, secondary post-trabecular glaucoma, and the deterioration of vision. This CT angiogram is showing the enlarged convoluted superior and inferior ophthalmic veins. This patient was treated with plugs or clips to occlude the fistula by an interventional radiologist. Orbital inflammation is the third etiology discussed in our lecture. It can be classified as acute, chronic, or due to thyroid-related orbitopathy. Chronic nonspecific inflammation was called in the past inflammatory pseudotumor. It is differentiated from chronic specific inflammation by pathological examination of a tissue biopsy. Acute orbital inflammation is usually called orbital cellulitis. Severe complications can result from orbital cellulitis, like cavernous sinus thrombosis, blindness due to either corneal exposure or optic nerve compression, septicemia, meningitis, and brain abscess. The orbital septum is a layer of fascia extending vertically from the periosteum of the orbital rim to the levator aponeurosis in the upper eyelid and to the inferior border of the tarsal plate in the lower eyelid. Any lesion or pathology lies behind the orbital septum, can compress orbital structures, causing proptosis and have a grave functional effect on vision, ocular motility, and pupillary reaction. This patient has got swollen eyelids and was suspicious of having orbital cellulitis. This girl also has got right orbital cellulitis. But to differentiate preseptal cellulitis from orbital cellulitis, we have to have certain criteria. In preseptal cellulitis, we wouldn't have proptosis, but in orbital cellulitis, The patient will have proptosis, the eye globe is pushed forward with limitation of ocular motility, and there is interruption of the pupillary light reaction and may interruption of visual acuity as well. This unfortunate patient with road traffic accident has got orbital cellulitis with severe proptosis and exposure keratitis. It is quite evident that in such patient, the inflammation is in the preseptal area affecting mainly the skin, so we don't expect to have proptosis in such patient. Infection can reach the orbit most commonly from the paranasal sinuses, but also it can get infected from the face, from the globe, from the lacrimal sac. Direct inoculation of the orbit from trauma or surgery, and also hematogenous spread can cause orbital cellulitis. Most of the time, with history taking, we can know the causative factor. For example, sinusitis, the patient will complain from runny nose, facial trauma or dental surgery, or infection anywhere in the body. The clinical picture as any infection elsewhere in the body will be redness and hotness, pain, swelling, loss of function, and systemic signs. We can apply the same principle on orbital cellulitis. Redness will lead to redness of the eyelids and hyperemia of the conjunctiva. Pain can occur with the eye movement or with touch. Swelling can induce proptosis, conjunctival chemosis, resistant to retropulsion of the globe, and elevated intraocular pressure. Loss of function. The function is usually vision. The patient can lose vision. There is interruption of extraocular muscle motility and pupillary reaction. The systemic signs of the systemic infection like fever, increased malaise, and nasal discharge. The patient should be hospitalized and should be given intravenous antibiotics. A CT scan has to be performed as soon as possible. Surgery is indicated if there is poor response to antibiotic treatment or if the CT scan shows a subperiosteal abscess. Thyroid-associated orbitopathy is a special entity of orbital inflammation. The clinical situation of the presence of eyelid retraction and proptosis with or without limitation of ocular motility is known as thyroid-related orbitopathy. The name of such syndrome was given thyroid eye disease because it was noticed clinically that 90% of such patients will have some sort of thyroid problem. On the other hand, when patients with Graves' disease were studied, it was found that about 25 to 50% will have eye manifestations similar to the thyroid eye disease. This percentage increased if the patient was smoking. The diagram on the left side shows the regulated production of thyroid hormone. The pituitary gland secretes thyroid-stimulating hormone that has special receptor at the thyroid gland cells. When enough thyroxine is released into the blood of the normal subject, there will be a negative feedback that decreases the production of TSH. The diagram on the right side shows an autoantibody which activates the TSH receptors on the surface of thyroid cells, and this will lead to unregulated overproduction of thyroid hormone. It seems that these autoantibodies will have a special receptor in the adipose cells and the fibroblasts inside the orbit as well in the skin, and they will lead to the accumulation of glucose aminoglycans and expansion of the orbital muscles. In addition to increase the amount of fat inside the orbit. It is well known that thyroid-associated orbitopathy is an autoimmune disease. We still don't know what initiates it, but we know it results in deposition of fat in the orbit and mucopolysaccharides in the muscle belly. The clinical picture of acute phase is conjunctival injection and ecchymosis, eyelid retraction, proptosis. Later on, the patient may develop muscle involvement, causing restrictive myopathy. And also, if there is compression on the optic nerve, it will cause the thyroid optic neuropathy. If we plot the severity of orbital manifestations against time, we will find that the disease reaches its maximum within 6 to 18 months, followed by slight regression of the disease severity, but changes occurred will never reach the baseline again. The value of early intervention is to halt the severity curve for the patient before it peaks up, so that when he reaches a steady state, he will be left with the least amount of deformities. In the quiescent stage, the patient is left with some deformities like eyelid retraction and proptosis. Patients with Graves' orbitopathy can be diagnosed by the clinical picture, either in the eye or systemic clinical picture of Graves' disease. We always ask for thyroid function test in addition to some antibodies that are known to increase during the active phase of thyroid associated orbitopathy. Mild forms of thyroid-related orbitopathy can be treated by conservative management plans like abstain from smoking, corneal protection, and sleeping with raised head to decrease congestion. More severe forms will require steroids intravenously are more effective than oral steroids, immunosuppressants like azathioprine and cyclosporin, or external beam irradiation. Severe form of thyroid eye disease that endangers vision because of optic nerve compression or exposure keratopathy might need surgical intervention in the form of decompression surgery. Surgical intervention most of the time is done during the quiescent stage, like orbital decompression, fat removal, which can be called fat decompression, extraocular muscle surgery to correct the double vision, correction of eyelid retraction. Orbital neoplasia is the fourth pathological cause for proptosis. Tumors of the orbit can be primary orbital tumors arising from structures within the orbit or extending from the surrounding structures, or metastatic tumors from anywhere in the body. Enophthalmos is another manifestation of orbital disease. The most common cause of enophthalmos is orbital blowout fracture. Blowout fracture is a protective mechanism that absorbs the impact of crushing force on the globe, which leads to sudden increase in the orbital pressure. The thin walls of the orbital floor and medial wall are fractured. Following orbital trauma, the patient will have swollen eyelids and black eye. Patients who develop double vision or infraorbital hypothesia are highly suspicious of having blowout fracture. Proptosis can occur initially due to surgical emphysema and retrobulbar hematoma. Later on, enophthalmos will develop. Large size fracture can cause displacement of the globe or hypotropia. Restrictive strabismus may occur due to entrapment of an extraocular muscle or its surrounding fascia within the fracture site. The management plan will depend on the presence of other ocular injuries that might require intervention. Radiological findings will determine what to do. If the fracture size is large, half the width of the floor or more, this will entail the need for rapid surgical intervention. Small-sized fractures are left alone if there is no limitation of ocular motility. But if ocular motility is impaired, a follow-up for up to 2 weeks will be required to give chance for spontaneous ocular motility recovery. If not, surgery shouldn't be postponed to prevent occurrence of fibrosis, which may lead to unfavorable surgical outcome. This CT shows entrapment of the muscle and its surrounding fascia within the fracture site. This is called the trapdoor fracture. In this CT, the right orbit shows large fracture with downward displacement of the whole orbital floor. The fracture will open the nasal sinuses on the orbital cavity so that the patient must be instructed to abstain from blowing his nose and should be given a prophylactic systemic antibiotic. When indicated, fractures are repaired by replacing the herniated orbital structures back into the orbit and by closure of the fracture site with a plate. Good luck and best wishes for the rest of your course in ophthalmology.